Is there a rational relationship between medical malpractice premiums and unfortunate medical outcomes?
Between premiums and outcomes? Well, historically the answer was no, because medical malpractice premiums were not what's called experience rated. And so if they're not experience rated, you know, and that's something that lowers the signal, because whether someone's practicing carefully or one's, you know, doing surgery while drunk, there may not be a relationship. But now, most premiums have some experience rating, so there should be some relationship, but it is muted. I mean, that's part of what insurance does, is spread the cost, and that does limit the signal. A lot of hospitals self-insure, so they're bearing the costs themselves. Here.
So you mentioned that we don't know enough to make a decision about whether malpractice affects patient outcomes. Is that because we don't know enough about patient outcomes? Because I imagine we have pretty good data on malpractice suits.
That's because it's hard to know to what degree malpractice law affects physician behavior, again, because there are many motivations, because what people report is not necessarily what they do. And the relationship, you know, there's just so, I mean, I'm not be able to help devising that study, but it would be it's really complicated to figure out the laws over here, the law. Then there are perceptions of the law, there are behavioral changes because of the law, which may or may not influence various medical actions, tests, etc. And then there's patient outcomes. And so there's just a lot of different stuff going on, a lot of confounding, and no one, you know, basically every study will start with, we don't know. So I didn't make that one up.
Well, yeah, just if I can comment.
Please.
Am I allowed to comment on the law?
Please.
So I think it's a really difficult thing to study, and there are circumstances, I think, where claims directly affect insurers, and insurers' payment, what they're having to shell out, directly affects improvement. So, for example, in Massachusetts, many of the claims, the disproportionate amount were OBGYN. And CRICO, which is the insurer for Harvard hospitals, was kind of fed up with all the payouts for litigation over OBGYN harms. So they began to do two things, as I understand it. They initiated improvement efforts and paid for them that were basically collaboratives where people came together and tried to figure out how we're going to lower the adverse events, and they began to incentivize physicians and hospitals with lower premiums if they were engaged in those efforts and were able to show improvement. So I think that's a virtuous cycle. Now they found that most of the claims are no longer surgical, they're in outpatient care, and so they put I think some number of millions of dollars into primary care. So I think that's, you know, something that isn't directly what you were saying needed to be studied, but it's nonetheless a good outcome of claims.
And that's, you know, that's how it's supposed to work, right? That's what the system is supposed to do. It's supposed to put in place that economic incentive, and that's a perfect example of what I call enterprise liability, of, you know, hospitals now having an incentive because of malpractice to institute better procedures and study it. What's hard to know is how you add up everything, right? The so-called defensive medicine on the other side. So what the overall impact is what's really hard.
Dr. Goodman, Goldman, the 100,000 lives saved and the 500,000 harms prevented, and your downward sloping curve that a time series would not show any effect between before and after those two campaigns. What are your thoughts about the downward slope? Was it adjusted just for those hospitals participating? Is it methodologic, or was it happening in an ad hoc way anyway? What's the story behind the line?
Yeah, so it is complicated, and you see the same lines if you adjust for severity of illness and type of hospital, all that kind of stuff. We made an effort to determine whether hospitals that participated in the campaign did better in that time period than those that did not. The trouble is that the people that almost 78% of hospital beds participated. So the comparison group of those who didn't are really very different, and probably not interested in improvement in the first place. And so that's hard to deal with. The good news, at least on the mortality, is that there has been a reduction year on year of mortality in U.S. hospitals as a whole. So that's the good news. And when you're having constant improvement like that, it's very difficult sometimes to sort out the effect of any one intervention. There are other interventions, there's other stuff going on in policy, there's technology advances, there's alarm over the Institute of Medicine report, a lot of things are going on. So to be able to attribute what happened in those 2+ years to the campaign is really, really hard when there's so many other things. In terms of the harms in that state, North Carolina, there I have a better sense, I think, of why we didn't see a lot of improvement. First of all, it's one thing to have a very dedicated state beating the drum and offering courses and having people get together and work on this. It's another thing to get the entire hospital, all of the wards, all the services, to adopt all of those best practices. Usually it's a team from one ward or two ward, and then they got to go back and sell it to the whole hospital, and leadership has to align with it. One way to call it is, what's the adoption and what's the coverage in the hospital. Secondly, there has been improvement in some areas of harm. For example, central line infections, bloodstream infections, and MRSA infections are and have been going down quite precipitously nationally. That's only a small proportion of all harms. Remember, we were looking at all types of harm, and the evidence about reducing some is better than the evidence reducing others. The focus on central line infection was very intense, not so much on the others. So to expect all-cause harm to go down in that situation is also difficult. One of the things that I wish we could do would be to have repeated that study 4 years later to see what the cumulative impact of kind of spread and attention would be over a longer period of time. So I don't get disheartened by the numbers. The hospital folks in North Carolina were pretty upset to see that all their efforts weren't reflected in a New England Journal paper. The good news to me was that there are some areas where we have great evidence, harm is going down, and if we do our knitting and keep at it and concentrate on getting it throughout all hospitals, not just in one or two wards, I think we'll see a change in that curve. One comment to just make, when we talk about improvement, we act as if quality improvement is the only thing that makes a difference in mortality and survival and harm and all these things in hospitals. That, of course, is flawed thinking. We focus on what we're passionate about, what we know. In neonatal intensive care, which I spent a fair amount of time both clinically and also in investigation, the babies who were 1,000 grams when I was in training almost all died. Nobody at 750 grams survived virtually. Now it's routine for babies of 1,000 grams to survive, and many, many babies at 750 grams survive. Now these are tiny. For those of you who've never been in a neonatal intensive care unit, a laboratory rabbit that's used in the experiments we do is 2 kilograms. These babies are under 1 kilogram. They're smaller than one of those laboratory rabbits. They're tiny, tiny, frail things with very poor immune systems. I can tell you that over the period of time when those babies started to survive, the neonatal intensive care units have never heard of Don Berwick or the IHI or quality improvement or campaign or the great work you do. They were dedicated caregivers with major advances in therapeutics and technology who cared a lot and were doing their best to implement that stuff. So surfactant, which is something that helps the lungs open up in very premature babies, was invented by Mel Avery at Boston Children's Hospital and adopted very, very widely, very quickly, because babies who died now live. So it's a combination of synergy between advances in technology and medical care and then getting those advances to be used every time in the right way so that you can get even better results. It's synergy.
It seems to me that from a research perspective, medical errors might be viewed as a subset of professional human errors that occur in a wide variety of fields. After all, errors occur in the field of education, errors occur in the field of management, strategy consulting, investment advisory services, software development, public accounting services, legal services. So I'm wondering whether any research has been done, A, to compare the rate of professional errors in other fields with that in the medical field, and B, more importantly, has research been done to see what has been done in other professional fields to reduce these kinds of errors, to see what might be applied in the medical field. Okay.
I mean, Don might be able to give more specifics about this, but I know that the healthcare field has learned a lot from the airline industry in terms of some of the work that they did with checklists and some other things to reduce errors, and also from Toyota, right, and some of the other industries like that. So you can probably give more detail, but
yeah. No, the whole basis of improvement in healthcare to reduce errors is based on what's called human factors research from other industries. So, as an example, I like to cross-country ski, and I use good old skis made by Parmet in Norway that use real wax. And one time I was really tired. It was dark, and it gets dark really early in the winter. And my kids were young, and they were screaming and crying about when are we going to get started. And I left the house without taking my wax, and I had my skis but no wax. Well, that's pretty bad, and that's because I didn't have a system to put the wax with the skis and had to remember in all this chaos to go get my wax. And then headed towards Vermont and found myself on the road to work because I'm like an old pony looking for the straw, and I go to work when it starts. So these are human factors, slips, lapses that can be mitigated and corrected if you have a really good system. So that's, I think, what we need to work on. But even these we call them high reliability industries, like the airline industry, the Alcoa aluminum became virtually error-free. We can have lots of examples. They all have a blind spot. So the airline industry, absolutely the safest it's ever been. I mean, I'd rather be on an airplane than on any highway any day. The airline industry never paid attention to security. So we had 9/11. The security, the security system for preventing a terrorist from getting on the plane had never been thought through. There was no system for that. It was chaotic and error-prone. Now we suddenly have systems that may or may not be good systems to prevent that, but the lens was never on that. In Japan, the land of Toyota, Fukushima occurred, which was riddled with misjudgment, error, poor system, because they thought they had a fail-safe system, but it never thought not just about the earthquake, but about the tidal surge. So there's always opportunity, and wherever working under the street light is not necessarily showing where you're going to fall when you walk out of the beam.
Hospital-acquired infections and other medical errors have been a major problem for decades. Cause of death, preventable in many cases. And for the most part, I think it is well known what ought to be done. What has kept hospital administrators from kind of cracking down and insisting, as the airline industry has done and others that you're talking about have done, to prevent what has been known to be preventable errors for many decades?
Have to answer that.
Yeah, I mean, we ask the same question, so, speaking like a consumer, because we say, why don't you just wash your hands? And, things that are known to make a difference. So then you see all these hospitals having campaigns with video, funny videos or whatever the campaign at the moment might be to try to revive that interest in washing hands or kind of, but yeah, as consumers, we say, just do it. So you probably can give more academic.
Yeah, I can be more academic. No, not really. I'll tell you a story. I work in infection prevention. That's my specialty. And I've done a lot of research in that area. And there are many studies that show what works, good clinical trials. Everybody knows you ought to wash your hands. I mean, I've written ad nauseum on that. So, what's going on here? I came home one night to talk about hand hygiene, hand washing, and the latest efforts. I had this little piece in the New England Journal. And my wife turns to me, she said, it's been 30 years, you're still talking about hand hygiene. Why do you still have to talk about that? Why isn't it solved? So it's a very good question. I think that we've bought into this idea that when it comes to infections, the patients are sick and they were inevitable. I mean, we had this feeling that that you could prevent some, but really they're part of doing business in a hospital because the patients are so sick and these catheters are so terrible, and on and on and on. It wasn't until we began to focus on this and actually see success that people began to think, well, maybe they're not inevitable. Maybe in fact we get close to zero, and that was pretty catalytic, I think. And improvement played some role in that. Beyond that, however, again, technology plays a role. So it would not be possible, I'm really pretty sure, in 1970 to get to where we are now with these catheter infections. The catheters were made of stiff polyethylene. They caused irritation in the vein. They caused thrombosis. We didn't have good connectors. Just technologically, they were inferior to what we have today. Today, they have hydrophobic surfaces. They're flexible. They're this small. The connectors have antiseptics in them, and so forth and so on. So you have to have that soil on which to build the improvement in order to really see the results. So I think it's no excuse. I think there's a lack of accountability. What I wrote in that little piece in the New England Journal was that if you go into Intel, they have these clean rooms with millions of dollars of chips. And you go through an anti-room and you grease and you gown and you put hats and gloves, and there's a video camera there, and the first time you screw up, you get a warning. The second time you can be fired because there's accountability. This is a social norm and an accountability issue. And in most hospitals, there isn't the social norm and there isn't no accountability. Nobody gets their privileges suspended for not washing their hands. At least they didn't until recently, and a lot of hospitals now are saying, we put the alcohol hand with the Purells on the board. You told us where you wanted it. We followed you around and placed it exactly where you need it, so you can't complain about that. The dispensers always work. They give you the right amount, and we've trained you, and you've shown us that you know how to do it. So what is the problem? And I think accountability has a role.
I think we have time for just one last question.
Dr. Bowling, you talked specifically this evening about dealing with the hospitals, and my question really is what's being done with private physicians in dealing with some kind of errors. And I think if you're specific, dealings with people with infectious disease, I'm sure that you vet many of these on a one-on-one sort of thing. So in your profession, uniquely to you do certain things and you don't do certain things so that you don't get sick along the way. But what are other physicians or private physicians doing, and where is this kind of check and balance that's going on that the IHI does for hospitals with private doctors?
Yeah, they're picking on me, right? So first of all, the what's done in private practice and in ambulatory clinics and so forth is way behind what's done in hospitals. And there are a lot of reasons, I think, for that. There haven't been many studies to show what is appropriate in that kind of setting. That they're extremely busy. You know, we work on a 20-minute at best rotation. The patients come. So there are a lot of mitigating circumstances. That said, there's now is a focus on this, and some of the things are maybe a little complex to solve, but they're obvious what needs to be done. So, for example, you know, just looking at you, I would suspect that you're probably of an age where you ought to have colon cancer screening. And I could be wrong. I mean, you know, I think you're at least 50. I don't know. So the question is, does your primary care provider have a reliable system that tells him this guy's 50 and he meets the guidelines, and so if he hasn't come in for a visit, we're going to reach out to him? Or if it's been 10 years or 5 years or whatever your program is, they remind you. So most don't have computer systems or systems to remind you. Then you come in and you get your screening, and the question is, what happened with that? So let's say you have a stool blood test that they give you a card to take home, and it's positive. Do they have a system for then following up so that you get the right care and follow up for that? Or if they send you a specialist to get a colonoscopy, do they know what happened with that and what the follow-up was? So very few practice, and we're studying that. We have an ongoing project in Massachusetts with the state as the lead to work with ambulatory practice to look at these very simple things. What's the conversation with the patient? I try and have a simple way of expressing my uncertainty with the patient. So most physicians feel they have to have the answer, and they have to say something, a solution. The way I look at it is there are basically three categories. I have a very good idea what's wrong with you, and this is what we need to do. Let's decide together how we're going to accomplish this. So I have a high degree of certainty about what needs to be done. Then there are issues where I have some degree of certainty, but I'm going to need to know more over time about that patient and to really get to know them well enough to figure it out again with shared decision. And then there are patients where I don't have a clue. And I tried to train myself to say, you know, I'm so happy that we're here looking at your daughter's condition and what's going on. It sounds really difficult. I have to tell you that I don't have an answer. And doing a lot of tests and doing CT scans blindly without having any sense of what needs to be done isn't something that we ought to embark on. So let's observe together over time, keep in close touch, and we'll figure it out. But this idea that I'm very certain, I'm sort of certain and think we need to do some stuff, and I have no idea, and we're going to have to be patient and figure it out together, is very helpful. And that's the kind of stuff we need to deal with in primary care.
And there are public reports on primary care, although not as much on errors, but you can look at some quality care measures for primary care practices in Massachusetts.
I want to thank our speakers for terrific presentations.